And today our discussion is about the Liddle syndrome. And Liddle syndrome is also included in the tubulopathies that is mostly congenital. This is the congenital tubulopathy, and in which there is the gain of the function of epithelial sodium channel. So let's draw together. This is the distal or the cortical collecting tubules, right? So you know that here is the epithelial sodium channel. There is the epithelial sodium channel that is involved in the reabsorption of water and salt, and in response it is secreting the hydrogen and potassium. And epithelial sodium channel is of great importance when it comes to the sodium retention, right? So it is involved in the sodium retention. So let's write, in Liddle syndrome there is the gain of function. There is gain of function of epithelial sodium channel. It means that this channel is going to work extra, right? Gain of function of epithelial sodium channel in the distal part of the nephron as well as in the cortical collecting tubules. Mainly the epithelial sodium channel is present in the principal cells as well as it is present in the alpha and beta intercalated cells. So when this epithelial channel is working more and more, it is working extra, so large amount of sodium will be reabsorbed, and subsequently there will be loss of hydrogen, that is proton, and the potassium into the urine. It means that we are going to have the symptoms of hypokalemic because potassium is being lost, hypokalemic metabolic alkalosis because hydrogen is also being lost along with the potassium. So it means that there will be hypokalemic alkalosis, and in addition to hypokalemic alkalosis there is hypertension. There will be hypertension. Hypertension is only the feature of Liddle syndrome. Hypertension is not present in Bartter and the Gitelman syndrome because, in spite the functioning of RAS system, in Bartter and Gitelman syndrome, there was no hypertension because the pathologic process overrides the physiologic process. But in Liddle syndrome, the hypertension is one of the most important features, and due to the hypertension, the RAS will be deactivated, and it's very important. The RAS system will be deactivated, and it leads to low renin levels. It leads to low renin levels, and this is one of the most important type of hypertension, and that's why it is known as low renin hypertension. And it's very peculiar that almost in all conditions, whenever there is renin increase, there will be hypertension. But this is the hypertension in the Liddle syndrome, in which there will be a low renin hypertension, right? It's of great importance when it comes to the concept of renin and hypertension together. And in the patients of Liddle syndrome, there will be no um, symptoms of dehydration because already the water and salt are being reabsorbed in great amounts, so dehydration will be absent in such patients with Liddle syndrome. And as far as the treatment is concerned, let's write treatment. Treatment for the Liddle syndrome patient is that we need to block or we need to inhibit the sodium epithelial channel, right? We need to inhibit this particular channel. So there is a particular diuretic known as amiloride, and it is known as potassium sparing diuretic. Let me explain how it going to spare the potassium. The name is amiloride, and amiloride is known as potassium sparing diuretic because when it's going to inhibit or block the function of sodium epithelial channels, subsequently the loss of potassium will be low. The loss of potassium will be low. loss of potassium will decrease, as well as the reabsorption of sodium will also be decreased. And that's why in case of Liddle syndrome we are going to inhibit this particular channel with the help of a diuretic known as the amiloride. And amiloride is being used in the patients with the Liddle syndrome. Let's talk about the some important aspects regarding the hypokalemic metabolic alkalosis. When it comes to hypokalemic metabolic alkalosis, there are several conditions in which the hypokalemic metabolic alkalosis will be there, right? So let's talk about them one by one. First of all the conditions in which there is high aldosterone, because the function of aldosterone is to reabsorb sodium and water. Along with there will be excretion of potassium and hydrogen. So hypokalemic metabolic alkalosis will be in all conditions that have hyperaldosteronism. So first of all is the Conn syndrome. There can be Conn syndrome or Conn's disease depending upon the understanding. Conn syndrome, as well as the bilateral adrenal hyperplasia. Bilateral adrenal hyperplasia, it's not congenital, because in case of congenital adrenal hyperplasia there will be low aldosterone adrenal hyperplasia. In case of Conn syndrome, as well as the bilateral adrenal hyperplasia, there will be increase in the aldosterone levels, and this aldosterone is going to cause hypokalemic metabolic alkalosis. The second is the Cushing's disease. And Cushing's disease is very important because Cushing disease does not result in hyperaldosteronism. It is only going to increase the level of cortisol inside the blood, right? But this cortisol will act as if it is aldosterone. This cortisol will affect the sodium epithelial channels. It is going to activate those channels. So in spite the cortisol is being released in Cushing's disease, this cortisol is enough to cause hypokalemic alkalosis. So the next thing is chronic vomiting. The patients with GIT disorders, like for example chronic vomiting, in case of neonates there can be congenital hypertrophic pyloric stenosis, there can be healed peptic ulcer disease, right? In all such conditions, healed peptic ulcer disease, as well as the in geriatric age group, there will be cancer of stomach. Geriatric means the old age, right? Cancer of stomach. So the conditions in which they will be vomiting, there will be chronic hypertrophic pyloric stenosis as far as neonates are concerned, healed peptic ulcer disease, and the cancer of stomach, there will be hypokalemic alkalosis of metabolic type. Because in case of vomiting, the person is vomiting HCl, right? HCl. The loss of fluid will contribute to the function of RAS, and again the aldosterone is increased in such conditions. Having discussed that, the most important condition is ascites, because in ascites there will be accumulation of fluid in the abdominal cavity. Okay, so there will be accumulation of fluid in the third cavity, right? This fluid is not present inside the circulation, it is present outside the vessels in the abdominal cavity. And ascites can be due to the conditions related to hypoproteinemia, for example liver cirrhosis. In case of liver cirrhosis, the liver is not functioning and it is not producing albumin. So low levels of albumin can lead to ascites, liver cirrhosis, as well as the chronic heart failure or congestive heart failure, as well as the conditions relating to the nephrotic syndrome, because nephrotic syndrome will cause proteinuria and a lot of protein has been lost into the urine, so it causes the development of ascites nephrotic syndrome. Other tubulopathies like Bartter syndrome and the Gitelman syndrome and the Liddle syndrome, they also contribute to the development of hypokalemic metabolic alkalosis. Gitelman and the Liddle that we have discussed today. These three tubulopathies that are in congenital in origin, they also contribute to the development of hypokalemic metabolic alkalosis because of the either it can be due to RAS activation in these two conditions, and in the Liddle syndrome due to the gain of the function of sodium epithelial channels. Let's talk about the treatment of these conditions. In case of vomiting related diseases like GIT related diseases, it can be cancer of stomach, heel peptic ulcer disease, it can be chronic hypertrophic pyloric stenosis. In all conditions, these all conditions are saline responsive, right? If we give such patients normal saline, that is 0.9% saline, these all conditions will respond to the normal saline. Or we can write saline slash chloride responsive because the normal saline is containing chloride as well as the sodium. So we can say that in case of vomiting, if we give such patients saline, that is 0.9%, and or chloride, they will respond to saline, okay, saline administration. But in case of other conditions, these all conditions are saline non-responsive, and in such conditions we have to give an other treatment, right? Alternative treatment should be given. In case of Bartter syndrome, we have discussed that due to the elevation of prostaglandin E in the antenatal Bartter syndrome, right? So we can give indomethacin in such conditions, indomethacin in case of Bartter's, right? And in case of Gitelman syndrome, the Gitelman syndrome had no specific treatment, and in case of Liddle syndrome, we can give amiloride as to inhibit the sodium epithelial channels. What about the Conn syndrome, the Cushing's disease, like right the ascites? In all such conditions, we can give spironolactone. Spironolactone, and spironolactone is aldosterone inhibitor, right? Spironolactone is aldosterone receptor inhibitor, and it is going to diminish the function of aldosterone, and it's going to treat the hypokalemic part as well as the alkalosis part. Because aldosterone has been inhibited, so sodium reabsorption will be less, and potassium and hydrogen excretion will also be reduced in response to spironolactone. So this was in general about the hypokalemic alkalosis, because hypokalemic alkalosis was coming again and again in all the tubulopathies. So it was worth mentioning about such conditions in which it develops, right? And in the next lecture, we are going to discuss about the diabetes insipidus. So this was for today.